Hi, my name is Amanda and I am now a Foundation Year 2 doctor, and I've had the great pleasure over the years of meeting some of you, and I understand that a lot of you are also embarking on your journey to becoming a doctor or have already become doctors, so I thought I'd make this ultimate survival guide so that you know how to thrive in your first year working as a doctor. So I'm going to tell you the checklist of things that you need to have sorted before you start your first shift, or at the very latest, at the beginning of your first shift. You should have somewhere saved all your logins for all the different systems that you may need to access, as well as what time your day shifts start and end, as well as what time your out of hours shifts start, depending on whether they're weekends or whether they're night shifts, because not many people are based where their day shifts are, as well as where handovers take place. You also want to know where the rest facilities are, as well as who your clinical and educational supervisors are, and have your initial or induction meetings scheduled so that you can hit the ground running and start getting your sign-offs from the beginning of the year. Last but not least, you want to know how much annual leave you're entitled to, as well as who your rota coordinator is. Also, do keep in mind that if you work any bank holidays, you will get time off in lieu. So for example, if you work a bank holiday, you'll have an extra day of annual leave to use up. Now let's move on to ward rounds. In essence, ward rounds are when the specialist or the consultant that is looking after the ward or consultants basically review each patient and come up with the up-to-date management plan. What I would do is I would follow a template. So this is how I was taught to do it and how a lot of people do it. I would always write the heading of what ward round it is, as well as the date and the time at which the patient is seen. That's very important because it will show any delays or sort of the chronology of when things happened. I would always then put the diagnosis of what they come in with, as well as their current issues. Now these are two distinct things, and I would put what is going on with that. So if they have an AKI, is it resolving? When you prep the note, so this is all the writing that you do before the specialists come, you want to preempt their questions. What are they likely to ask me about? Are they on antibiotics? Where is the infection coming from? Have we involved any other specialties? Is it resolving or is it getting worse? What's their white cells saying? What's their inflammatory marker saying? So this is what you want to preempt when you prep the notes. So once you write the current issues and what the current situation is, I would include what scans are coming up and when they've been scheduled for, the most recent blood tests, especially highlighting the ones that are sort of deranged, and in brackets putting the previous result. For example, if I tell you someone has a white cell count of 15, you may be like, oh my god, we need to start antibiotics. But what if I tell you that they were 22 yesterday? That shows that they're improving. It paints a very different picture. Now that brings me on to my next point, which is ward jobs. Now, ward jobs are essentially, as I said, after the consultant has reviewed the patients, all the jobs that you have to do to make sure that the management plan gets carried out. And I've seen really fancy, elaborate ways of prioritising jobs, but I use a very simple traffic light system, and I recommend this because the simpler, the more efficient, the better in my eyes. Red are your absolutely urgent tasks. So the way I think about this are what tasks, if you don't carry it out immediately, will potentially have a clinical consequence. An example of something that I would highlight as red is a patient who is scoring and who's clinically unwell and that needs to be reviewed. Another task that for me would be red would be the clerking of a new patient. It's not always clinically urgent, but I would suggest just having a brief idea of what the patient has come in before you label them as being red, amber, or green. For example, the patient that's been admitted that you need to clerk may be a patient that's come in following a fall that is on blood thinners. This is definitely something that you need to attend to urgently. You may need to order a CT head, you may need to pause their blood thinners, or speak to other specialties. And this is a patient that could potentially deteriorate, so you need to see. On the other hand, you may have a patient that's come in for a procedure the next day, they've already been clerked in another department, and everything's done for them, they're very stable. It's an elective procedure. These are two different situations. The latter situation, you can afford to get to in a couple of hours and do something else. Another situation that I would label as red is any time-critical prescriptions. Is someone hypertensive and they need fluids? Does someone need antibiotics for sepsis? Does someone need their, as I said, anti-Parkinson's, blood thinners, diabetic medications prescribed and they haven't already been? Also, any urgent scans that need vetting. And last but not least, any patients you need to urgently escalate. I would label a task as being amber urgency if it will have a knock-on effect, but the patient is stable. So if you need, as I said before, specialty referrals and then waiting for their response, or bloods or imaging, but the patient is stable and it's not going to sort of have an immediate consequence. Urgent discharge summaries, for example, they have a package of care starting. I would label something as being green if it can likely wait till tomorrow. I would get to this last. For example, someone's going home tomorrow, organising routine outpatient referrals that they'll need when they get home. Clerking is when a new patient comes in and you make sure that they have everything they need before the specialist sees them, so that they can be medically stable, and to make sure they have all the parts in place so that we can get to the bottom of their diagnosis and we can start an early management plan. So when you clerk a new patient, I would always take a full history, do a head-to-toe examination, order any scans and bloods that you think the patient might need in order to narrow down the differentials and get to a diagnosis. I would prescribe all their regular meds using their GP history as well as the patient's own history, because sometimes they may say, oh, I stopped taking that ages ago, I actually haven't been on it. Especially important, as I said, to prescribe the time-sensitive or critical medications. Alongside the prescribing, I would prescribe any PRNs that you think they might need. So these are the ones that they use for symptom relief. For example, if someone's come in with a hip fracture, they're likely going to be in a lot of pain. So you should use the WHO pain ladder to prescribe them some pain relief. And think about their renal function when you do this, their age, as well as VTE prophylaxis, or at least come up with a rationale for why you want to give VTE prophylaxis, whether it's TEDs or like a low molecular weight heparin like enoxaparin, as well as pausing any medications they shouldn't have. For example, if someone's come in with frank hematuria and they're on a DOAC, you may need to pause that DOAC while we get to the bottom of their hematuria. Try and find a way to see if they have any outpatients appointments coming up, or if they're under a specialty. For example, if someone comes in with vomiting, but they're under a gastro consultant for cyclical vomiting, you will manage a patient completely different if it's a flare-up of a chronic condition that they're being seen compared to if it's a first presentation of something. Then you also want to come up with a little bit of a management plan, and to do this you can use trust guidelines, ask your ward pharmacist, any other doctors that are with you in the office at the time, and then you want to discuss it with a senior. So sometimes the senior will automatically come and then clerk the patient after you have. But if it's really urgent, then I would give them a call. Documentation, to me, is a little bit like driving. With driving, you eventually become good enough that you go on autopilot. And it's only when you go on autopilot that something bad happens. My sort of litmus test for this is, could this be questioned later? And that tells you how thoroughly you need to document something. For example, I'm not saying that if you prescribe paracetamol to a patient, you need to document it by any means, but let's say a patient is threatening to self-discharge, you're doing a capacity assessment and you're, putting a DOLS in place and saying that someone cannot self-discharge. Those are all situations that could 100% be questioned later, or if a patient is deteriorating, and that you want to make sure that your documentation is ironclad. The one time that you do want to always document is if you actually see a patient, if you examine them, if you speak to them. Some important resources that I recommend you check out if you're a newly qualified doctor is MedCalc. They have all the really good sort of calculations or scores that you may need, for example, for the Wells score for P or DVT, the AMT for a confused patient. I recommend the Perioperative Medicine's Handbook. You type in any medication and it will tell you what to do before, if they have a procedure coming up, after the procedure, whether you want to pause it, for how long, whether you should hold it, and depending if it's an elective or an emergency procedure, to recommend it if you're working in surgery, and Accurex as well, which is basically gives you the directory or the numbers for anyone in your hospital. How do you get your body clock adjusted to working a night shift? Now, what I did is that the day before you usually have off, and I recommend staying up really late, so talking about 2-3 a.m. I also recommend in your night shift, of course you can have coffee, but try not to have coffee about 4 to 6 hours before your shift ends. So I also recommend eating right before your shift ends, because you will wake up from hunger. I also recommend doing everything you can to help you get a better night's sleep. So shutting off all the curtains, wearing an eye mask, earplugs in if you need to. Please don't feel guilty about not doing anything on your night shift. You do hear of some people that continue to go to the gym during your night shift. When I'm on a night shift, and I know a lot of people are like this, I do not exist to the world. My entire personality is that I'm on that night shift. I will not do anything but eat and sleep. At handover, I recommend handing over the patients that are unwell and outstanding tasks that you have. You don't need to hand over everything, but anything that you may think may cause them some issues, that it's good for them to sort of preempt. And when you see a patient, ever the presentation, just do your A to E, and you will at least have a very good examination that you can hand over to a specialist who will know more than you and who can likely piece things together a bit better. And when you speak to a specialist, do your SBAR handover that you've been taught. And if there's any patient you feel that you're sort of losing the grip of being able to manage, or you feel like you're feeling out of your depth or they're becoming unwell, escalate to your senior. It always helps when you're calling a senior if you tell them what you've done. And also, I recommend telling them what your train of thought is. So what do you think it might be? This is really good because it helps you be a more independent doctor. They can tell you, yes, you put all the pieces together and I would recommend the same. But if they say, no, I think that's unlikely, I think you should do this instead, it also makes you learn from that experience rather than just telling them, so what is it? What do I do? Ask yourself what can wait till tomorrow. Some people will get you to do some crazy tasks at 2 a.m, but tell yourself, is this going to change the patient outcome? And actually, with the day team, with all the facilities that are open during the day, all the services that are running, would they be in a much better position to solve this and hand it over for tomorrow? And always go on your breaks. And now let's talk about some of the life admin that you're expected to do as an F1. Book your induction and end of placement meetings early. Do DOPS and CBDs throughout the year. And in terms of early career planning, absolutely make the most of your taster weeks. It is, at the end of the day, 5 days paid off the ward where you can do whatever you want and get involved in a QI project and an audit. You can speak to your supervisor about getting involved in this, and check any portfolio or entry requirements from the beginning so you know to hit the ground running. So before we finish the video, I just want to say that a lot of people like sort of highlighting the stress, the burnout, the lows, and my opinion is that medicine, the highs are as good as the lows. I have loved F1. I think the camaraderie between other doctors is incredible. You will meet on a night shift someone that you've never met before that seems completely different to you, but because you're bound by the same stresses and everything, you'll automatically sort of come together, and there's an incredible sense of community that I think is unlike any other workplace. It really takes me back to when I was 17 and I was writing my personal statement and I was like, wow, this is what it's like to be a doctor. And then I got into medical school and I was like, it seems so boring. I'm just going on placement, being an observer. But now coming out the other end where you are actually, managing an unwell patients, and people say it's all discharge summaries and admin work. It can be, but there are times where you really do feel yourself becoming a doctor, and it's an incredible feeling. Just remember, it's a slow process, okay? You will feel a little bit incompetent sometimes. You will feel anxious that you don't know something. Please don't, let me tell you how anxious I was about bloods and cannulas as an F1, and it's only at the end of F1 that I feel somewhat confident in it. But talk about this with your peers, because a lot of people keep it in themselves and then they feel incompetent to the people compared to the people around them. But that is the end of the video. Don't forget to comment if you have any more questions, like and share. Follow me on Instagram because I post a lot more on there. And I hope that F1 goes great for you, and I look forward to seeing you in the next video.